Most doctors go into medicine to fix things. Order labs, make a diagnosis, prescribe a treatment, move on. Psychiatry breaks that loop. There's no scan to confirm your diagnosis, no biopsy. Two qualified psychiatrists can see the same patient and reach different conclusions, and both can be right. Some of your patients won't improve for years, some won't improve at all. And yet, psychiatry attracts some of the sharpest minds in medicine. Dr. Jubbal, MedSchoolInsiders.com. Today, we're breaking down the 6 signs you're wired for psychiatry and the one thing that will tell you faster than any rotation whether this doctor career is for you. The first sign is how you respond when a patient becomes a threat. Healthcare workers in psychiatric settings are assaulted at higher rates than those in any other clinical environment. Most med school rotations won't prepare you for that. Patients in active psychosis can turn without warning. Someone cooperative for months can become aggressive in a single session. Drug-seeking patients are practice manipulators, and recognizing that doesn't make managing them any easier. Community psychiatry adds another layer the inpatient unit doesn't prepare you for. Patients who disappear, who show up intoxicated, who have nowhere to go after the appointment ends. You can do everything right and watch someone deteriorate anyway because the conditions of their life make recovery nearly impossible. The psychiatrists who build careers here aren't immune to this. They're curious about it. What is the aggression protecting? What does the drug-seeking behavior tell you about what the patient actually needs? A difficult patient, read carefully, tells you more than a cooperative one ever will. If someone's being hostile toward you, do you find yourself wondering why, or do you get flustered and start looking for the exit? But handling aggression and absorbing someone's pain are two different skills. A patient describes something unbearable, abuse that lasted years, a suicide attempt they're not sure they regret, a mind that has turned completely against them. You can't fix any of it, and you have another patient in an hour. Most doctors maintain some clinical distance. You read the scan, interpret the labs, operate. In psychiatry, what someone brings into that room lands on you directly every session across years. Think about the last time someone close to you was going through something devastating. Did it pull you under with them, or could you be present without it derailing your own life? Multiply that across every patient and every session. The psychiatrists who burn out can't separate their patient's pain from their own. That's not a flaw in their character. Psychiatry will just extract more from them than it returns. The ones who last know where they end and the patient begins. That steadiness with a suffering patient is the same thing that keeps you functional when there's no clear diagnosis. Every other specialty has a primary lens. Cardiology looks at the heart. Orthopedics looks at the skeleton. Even the broadest specialties work toward a diagnosis with something objective to confirm it, like a scan, a lab, or a finding. Psychiatry doesn't have that. Two patients who describe identical symptoms may need completely different treatments because the same presentation can come from completely different causes. One person's depression is biological, another's is rooted in trauma they've never processed, another is trapped in desperate circumstances. Same words on the intake, completely different work. There's also no test that confirms you're right, no result that tells you the treatment is working before the patient does. You build a picture from conversation and observation. You might try 3 medications before finding one that works, or revise the diagnosis entirely a year in. Psychiatrists have to hold all of that at once and figure out which layer is driving the problem. Some doctors need a clear path to follow. Others get restless when the answer comes too easily. Psychiatry takes away the diagnostic tools other specialties rely on. It also takes away the procedural ones. Psychiatry has no procedures, no OR time, no suturing, no technical skills to develop. Diagnosis and treatment run through conversation in a way no other specialty requires, though medication management is a significant part of the job. For some medical students, that's a relief. For others, it's a deal breaker they don't discover until 3rd year, when they realize how much they came alive in the OR and how flat everything else felt by comparison. If you've ever found yourself wanting to repeat a procedure or gravitating towards skill labs during preclinical years, pay attention to that. Psychiatry won't give you that feeling. The doctors who thrive here don't miss it. They're reading what someone isn't saying, noticing how a patient's presentation has shifted over 6 months, deciding when to push on something and when to leave it alone. For the right person, that's where the work gets interesting. What fills that space is the patient in front of you across years. Psychiatry is one of the only specialties where a 1-hour appointment is standard. Patients come back weekly, sometimes for years. That's just how the work gets done. The relationship itself is part of the treatment. A patient who trusts their psychiatrist responds differently than one who doesn't, and that trust is built over dozens of sessions, most of which feel unremarkable in the moment. The payoff is slow and specific. Someone who couldn't leave their apartment when they first came in is holding a job 2 years later. You were part of that across hundreds of small moments that didn't feel significant at the time. If the idea of seeing the same patient for 3 years sounds repetitive, that's worth paying attention to. Some doctors are energized by volume and variety. Psychiatry rewards depth over breadth. But spend enough time with the same patients and you start running into the questions psychiatry hasn't answered yet. Neurology maps lesions. It finds the bleed, localizes the damage, and identifies the structural problem. Psychiatry works in the territory neurology leaves behind, like why someone hears voices, why a person can't feel anything, or why the same trauma destroys one person and leaves another intact. These aren't questions medicine has answered. Electroconvulsive therapy has been used since the 1930s and remains one of the most effective treatments for severe depression. Nobody fully understands why it works. A decade ago, ketamine for depression was fringe. Now it's in clinics. Brain stimulation treatments that were experimental when most practicing psychiatrists were trained are now standard care. The field is moving fast and there's no sign of that slowing down. The brain is still the least understood organ in the body, and some of the most effective treatments in psychiatry work for reasons nobody has fully explained yet. Does that excite you or frustrate you? Psychiatry is one of the most self-selecting specialties in medicine. If it's for you, you probably already know. The next step is understanding what the career actually looks like. We covered the residency, the subspecialties, and the day-to-day in our So You Want to Be a Psychiatrist episode, link right up here.